So I'd like to talk the intracoronary imaging for the calcium during PCI update to 2021. So let me start this case. This is 79 years old male and stable angina, and you can see the proximal LAD having the stenosis, and you can recognize calcium by angio. So this view, I can see the calcium both sides, and this view, I can see the circumferential calcium. So this patient suffered instantly stenosis, and then 1 year later, we performed the OCT at the first time, and we recognize there is a very under-expanded stent due to the circumferential calcium behind. That's exactly we see by angio. At this point, we perform the laser and then non-compliant balloon. Afterwards, you can see the nice calcium fracture behind the stent, making the good stent expansion. So we look into the comparison between the IVUS or OCT compared to the angio. In general, if you have the big calcium either by IVUS and OCT, you can recognize calcium by angio, as I showed before. However, sometimes OCT see the big calcium or IVUS, but we couldn't see the angio. So what does this mean? So this is a case example. You can see there is no calcium by angio, and we check the IVUS, and we recognize actually the calcium was quite large. And we look into the same case by OCT, and we recognize those calcium was quite thin. So those are the typical pattern which we couldn't see by angio, but we recognize by IVUS and OCT. So meaning the thickness of the calcium is thin, therefore the total amount of the calcium is not too much, and then we couldn't recognize by angio. So to look for this type of phenomenon, we look into the region which IVUS having the maximum calcium angle is more than 180, and then we compare the angiographic visible versus non-visible by OCT. And you can recognize the thickness of the calcium less than 0.5 in the majority of the cases which having the angiographic non-visible calcium. And then they are good stent expansion. So therefore, if you see the big calcium by IVUS or OCT, but you don't see calcium by angio, that's most likely indicating the thin calcium that doesn't inhibit stent expansion. So to make more clear, we developed the calcium score by OCT, and we see all the components of the calcium predict stent expansion, meaning the calcium angle or thickness or length. And based on the correlation, we developed the score. If the angle is more than 180, thickness is more than 0.5 millimeter thickness, or length is more than 5 millimeter, that's indicating the poor stent expansion. And if the score is high, we see the poor stent expansion. The mechanism of the stent expansion in the severe calcified region is making the fracture. So those are the cohort which was treated by balloon and stent only. And then we look for what is the parameter or threshold to predict calcium fracture without additional treatment. The pink dot, which showing the region which having the calcium fracture, and except this region, all of the region having the calcified fracture is thinner than 0.5 millimeter thickness of the calcium. So therefore, if the calcium is thin, they can be fractured. Otherwise, we have to do more. So we developed the IVUS calcium score and just published this month. And based on the learning of the angiographic appearance, we make a little bit modification compared to the OCT score. So the first we ask, can we see the angiographic calcium? Because we know if that is visible, that's more likely thick calcium. And if yes, we calculate the IVUS score. And based on the OCT score, we learned that big, long calcium is important. So we thought the calcium angle more than 270 and longer than 5 millimeter is important. And the second is circumferential calcium. That's very different compared to non-circumferential, Because if there is some place which don't have the calcium, there is a good chance to making the dissection. But if that is circumferential without fracture, we cannot make expansion. And also the calcified nodule is important. And the vessel diameter at the site of the calcium is important because that's indicating negative remodeling. That's less capacity to make the good stent expansion. So making the score, and if that is more than equal to 2, we consider the atherectomy. We can recognize calcium fracture by IVUS as well. And this is Pure, and you see the circumferential calcium. And after the rotor and non-compliant balloon, you see the calcium fracture. And after the stent, you see the good stretching of the fracture site, making the stent expansion. And sometimes we recognize calcium fracture by looking at outside of the tissue, which couldn't visible at the very beginning, but now is visible because there is no longer calcium on the top of this tissue. Based on the test cohort, we develop the calcium score and we validate and we confirm the calcium score is high, they are poor stent expansion. And we check the lesion which underwent atherectomy, and those we recognize if the calcium is score high, still they are good stent expansion. And finally, we picking up the lesion which don't see the calcium by angio. None of them having the very high score, but even high, they are good stent expansion. So that's very correct, meaning that if we don't see the angiographic calcium, more likely see calcium. So there is a very clear interaction in terms of the calcium score and stent expansion in relation to the atherectomy usage. Meaning that if the calcium score is high, if you do the atherectomy, you can get the good stent expansion. Last year and this year, we learned a lot about calcified nodule. So the calcified nodule can see as an irregular shape of the surface with acoustic shadow by IVUS and attenuation by OCT. Pathology, but in the pathology, that calcified nodule is really the accumulation of the small nodular calcification, which protruding to the lumen. This is the data from Japan. They including the lesion which underwent the atherectomy and then compare with without calcified nodule. At the end of the procedure, the stent area is actually larger, which having the calcified nodule. However, outcome is much worse in the region which having the calcified nodule compared to without. Let me show one case. This is 87-year-old male and progressive angina and severe MR and three-vessel disease and severe lesion in the mid-right coronary artery. And after the rotor and stent, we see the nice stent expansion. But 2 months later, the patient is coming back. And we perform the IVUS. And in the very distal, we see the thrombus. However, this is important. Inside of the stent, there is a calcified nodule inside. That's really only 2 months after the stent implantation. So this is a comparison in the Pure, and you see the calcified nodule was pushed by rotor and balloon, and after the stent, actually stent expansion is good. But 2 months later, we see the calcified nodule in the stent again. So this is the data by the pathologist. They show if there is a calcified nodule at the chronic stage, sometimes calcified nodule is protruding to the lumen through the stent slot. That's caused the recurrent or early instant restenosis, which we see in the case. And this is a case, there is a calcified nodule, and after the orbitary atherectomy, you can see the nice polishment of the surface by looking at the site of the wire bias and also the nice lubrication. And you can see the calcified nodule, and after the orbitary, looks like nodule disappear a little bit, but we don't know this is a good treatment. We have to look into more. Finally, the shock wave, you can see the very severe calcified nodule angiographically, and looks like very nice stent expansion. And we learn a lot by looking by OCT after the shock wave. This is the Pure, and after the shock wave, you see that a lot of calcified fracture, more likely circumferentially compared to the regular case, and making the good stent expansion. And this is a case which having the non-STEMI, and you can see that circumflex was totally occluded, but now is wired. And after the treatment of the shockwave, we put the stent and we see the nice stent expansion. But very end of the lesion, we recognize actually the stent was not expanded due to still the circumferential calcium. And then actually we perform the shockwave afterwards. And this is how it looks like. That's under expanded segment. After the stenting, we did the shock.
Can we have her back so that she finishes?
Shockwave, a nice calcified fracture, making the stent good stent expansion, which we never see without shockwave. So to summarize, 2021, OCT and IVUS calcium score has been established. The importance to recognize is total volume of calcium. But as I said, angiographic evaluation is also important to start with, and we need to understand the best treatment of the calcified nodule. And liberal use of the shockwave was a big game changer in 2021.